Good afternoon. Welcome back to the afternoon session of RheumNow Live. I'm Jack Cush, one of your co-hosts. Our next pod is called Vasculitis Evolution and Advances. We've got three amazing presentations followed by a half hour of Q&A. Our first speaker is good friend Dr. Robert Spiera from the Hospital for Special Surgery in New York City. We've asked Rob to come today and talk to us about new therapies for polymyalgia rheumatica and giant cell arteritis. Rob, the stage is yours.
Thank you very much, and it's actually interesting to be here, being able to talk about new therapies for GCA and maybe new therapies for polymyalgia rheumatica. These are my disclosures, and some of them are relevant because these are companies that have been looking at therapeutic strategies in these disorders. So I'm not going to talk clinically about these disorders. We're going to hear a little bit about imaging and trying to make diagnoses, but we recognize these are both inflammatory diseases that are common in the elderly. There's a very large universe of polymyalgia rheumatica, maybe the first or second most common inflammatory disorder of the elderly. There's a smaller universe of symptomatic giant cell arteritis. Actually, some of the PMR patients actually have asymptomatic GCA. I think you'll hear about that in the imaging section. But they overlap a lot. Both are very imminently treatable with steroids. They share a lot of common pathophysiology, so it's sensible to talk about them together. We think about them a little bit similarly when we approach patients. In any talk about therapy, though, we want to think about the goals of therapy. So, we're really familiar with this when it comes to inflammatory arthritis. We want to control signs and symptoms, and we want to prevent erosive disease. We want to prevent damage. GCA and PMR are a little bit similar, and a little bit different. The short-term goals in GCA, number 1, 2, 3, 4, 5, 6, and 7, is to prevent cranial ischemic complications. You don't want your patient going blind, and if they've already had visual damage, you don't want it to happen in another eye. That's catastrophic. But really, after the first few weeks of therapy, that's an extraordinarily rare event and isn't generally what we're thinking about most in the subsequent months and months or years in cases of therapy. We also want to improve the localizing signs and symptoms, things like jaw claudication or headaches. That also tends to respond quickly to high doses. And we want to improve the systemic inflammatory manifestations. And all of that is relatively easy at the beginning with steroids. But long term, we have other goals. We want to decrease late vascular complications. It's not in everyone, and it's actually in a minority of patients, but we know they have more aneurysms and whatnot. We want to minimize the adverse impacts of therapy, and we want to improve patients' long-term quality of life. Because you've all probably experienced these patients. They come in aged after 2 years of being treated for giant cell arteritis, and it's almost hard to quantify what is doing that to them. In PMR, it's much more straightforward because there's not the concept of disease-related damage, such as vascular complications in PMR. You want to make sure they're not developing giant cell arteritis, but you really mostly want to improve their quality of life and minimize adverse impact of therapy. So they're both imminently treatable with steroids, which we're familiar with, and are inexpensive. They're both unfortunately characterized by prolonged glucocorticoid exposure in a potentially vulnerable population. Flares and relapses are common in both, and comorbidities in both can make it hard to assess whether the complaint they're coming in with is a headache from their cervical OA or whether it's recurrence of disease. So I'm going to give a case, just as an illustrative case, and there's no right answer. This is a 74-year-old woman who was recently diagnosed with GCA. She presented to her internist with a prior history of fatigue and shoulder or thigh girdle pain suggestive of PMR, but then a headache prompting more urgent evaluation because she had been educated when she had PMR, or it was thought about, look for signs of GCA. So she's very anemic with a hemoglobin of 9.8, SED rate is 72, platelets are 468, and a biopsy was already done, it was already positive, and her internist already started the patients on 60 milligram of daily prednisone and was doing much better. And she comes to you for what is my next step. And she does have a history of osteoporosis stable on alendronate. So we have a bunch of choices here, and I loaded too much into it. But number one, do you just give a typical glucocorticoid taper with close follow-up? Do you add a disease-modifying medication or steroid-sparing medication if there is one? That could be methotrexate or tocilizumab with close follow-up and a steroid taper. And I'm going to throw in another wrinkle. Do you also add an aspirin daily, either with a glucocorticoid taper alone or with methotrexate as your steroid-sparing modality, or with an IL-6 inhibitor with tocilizumab as your steroid-sparing modality? So just pick how you would approach it. Okay, so that's pretty interesting, and I think really reflects how we're doing things here. A large number of people are using tocilizumab up front. A minority of people are using an aspirin daily, and very few people are using methotrexate. And I would not say there's a right answer. I would say that's very similar to what I do, but we can talk about that. And I'll give a little data in terms of how we would approach this. So there's a lot, the understanding of the pathophysiology of GCA has really afforded a lot of insights into potential therapeutic targets. And you can see glucocorticoids are relevant to most of those targets. But there are other strategies that have been looked at, including other sort of more conventional immunosuppressive therapies, other biologics, including abatacept, and of course IL-6 inhibitors, and now more recently JAK inhibitors. There's also a GM-CSF inhibitor that's been looked at a trial, but I'm not going to have a chance to go over all of these. But when we think about trials, just think about what are the outcomes that are utilized. And this is important, even though it can be dull to talk about, because you want to know what's relevant to your patient. So we could use sustained remission, but that's going to be a function of how quickly steroids were tapered in the trial. We could use steroid total dose or duration of dose, but we have to define what's an important difference in glucocorticoid doses. We could look at flares or recurrences, but again, that's going to be a function of how quickly things are tapered. And really in a PMR trial, for example, if a flare happens on 3 milligrams of prednisone and you have to raise it to 4 milligrams of prednisone, is that important? And then, late vascular complications are very important, but it happens so rarely you'll never catch it probably in a clinical trial. Adverse events, though, would be important. So we all feel that glucocorticoids cause adverse events, but do we have adequate tools to capture that? And there is a tool that's developed called the GTI, Glucocorticoid Toxicity Index, mostly relevant to higher doses of steroids. Maybe that'll end up being meaningful. And unfortunately, we don't have any great biomarker outcomes that are correlated with important clinical outcomes. So there have been many trials, and I said recent, but this is really over the last 20 years in GCA. I'll talk a little bit about some of them, but a lot of this is in the syllabus. I should mention there was a negative, well-done trial with infliximab. I won't talk about that, but I'll mention some of the other ones. So I want to parenthetically almost mention the aspirin issue, because this comes up. It's actually been provisionally, I think, endorsed or conditionally endorsed in the ACR guidelines. There's no prospective studies looking at this, but there's 2 well-done retrospective studies, and the references are in there, where they looked at people presenting with GCA and just said, did these patients have cranial ischemic complications or not? Did they present with blindness or a stroke? And then went back and looked at their medics and saw that if you happened to be on aspirin at the time of presentation, you were less likely to present with damage. So I don't know that this will ever be prospectively studied, but I often add an aspirin a day, especially if somebody's presenting with cranial ischemic complications or even threatening things like jaw claudication, and there's no contraindications. Well, what about methotrexate as a steroid-sparing agent? I'm just curious. I know we don't do hand raises here, but do many people here use methotrexate in this disease? It looked like less do than I might have anticipated. But there were 3 trials, 2 of which were negative. The negative trials, which included one we led, used a low dose of methotrexate, only a median dose of about 8.5 milligrams a week. The best done trial was Gary Hoffman's trial, which was a multi-center trial called the INSIST trial, looked at a good dose of methotrexate, 15 milligrams a week, and showed no benefit whatsoever to the addition of methotrexate. And in this trial, by the way, they used an alternate day steroid taper. And the main lesson from this trial is don't use an alternate day steroid taper in this disease. They had a 13.8% rate of new vision loss in that trial. But then Alfred Marr did an individual patient meta-analysis. So you take the individual data from all of these trials and do it as if it was one big trial, and was able to demonstrate that patients with GCA, if you add methotrexate, there is some reduction in the risk of a first or second flare and some reduction of cumulative steroid exposure, but was not able to show any difference in outcomes in terms of ischemic outcomes or steroid-related adverse events. And you would have to treat about 11 patients to prevent one relapse in a cranial relapse. So there's limitations to this. I would say I don't routinely do this, and one of my mentorship moments was Gary Hoffman not being an author on this trial because he felt one well-done prospective trial is better than a retrospective meta-analysis, and it was a lesson that stuck with me. This is a trial that actually the speaker after next was the lead author on, was a trial of abatacept in GCA. And abatacept worked. This was a trial where patients were randomized to abatacept. Actually, everyone got abatacept for a few months, the intravenous dosing regimen, and then some patients were randomized to receive placebo subsequently and some to active drug, and patients were less likely to flare if they had been treated with abatacept. So there's rationale for IL-6 inhibition in GCA and PMR. In the interest of time, I'm going to not dwell on this, but there's good rationale in both disorders. And the GIACTA study was the pivotal study that led to the approval of tocilizumab for GCA. Complicated design, 4 groups of patients. One group had a standard sort of 1-year steroid taper and placebo. 1 year had a rapid steroid taper to 26 weeks plus placebo. One group got tocilizumab every other week plus a 26-week taper. And one group got tocilizumab every week and a 26-week taper. And there was clearly a benefit to treatment with active tocilizumab. So the groups of patients who were randomized to placebo, only about 15% of them reached this outcome of sustained remission, meaning reaching remission by week 12 and then remaining in remission for the next 52 weeks. And complementary to that is the steroid use, not surprisingly, cumulatively was much lower in the group randomized to tocilizumab. So it was approved for use in this population, and I think it's an adjunct, and it's a useful adjunct to what we do. So there was acceptable safety, there was a good steroid-sparing benefit. But I always go back to this slide, which was in a case series by John Stone and Sebastian Unazzoni, where they demonstrated this was a patient with GCA that was refractory, had failed cyclophosphamide, was stuck on like 10 or 15 milligrams of prednisone, and with tocilizumab went into very much a remission and got down to 3 milligrams of prednisone. So in that context, she went for an elective surgical procedure and died of a myocardial infarction. And at the time of surgery, she had rip-roaring vasculitis in every vascular bed. So are we treating the inflammatory manifestations but not vasculopathy? And it's something we really have to think about. And we don't know how long to treat these patients for. I do want to say that the suppression of the SED rate in CRP to me is a big negative of tocilizumab in GCA, because especially in somebody who's lost vision already in one eye, I rely much more on the SED rate and CRP in that population, and losing them, which is really our only reliable biomarker, is complicated. So the way I approach the patient is I assess their phenotype, risk of steroids, always use a high dose of steroids up front. I try to taper to 0 by month 6. I do use tocilizumab early in most patients, and generally with aspirin, and I do not routinely use methotrexate up front. I consider clinical trials, and there are some good ones ongoing. And in refractory disease, I will think about methotrexate or abatacept. There's also a small trial that was done with secukinumab, which showed benefit. So I'm going to do this case quickly. This is a patient with polymyalgia rheumatica, 6-week history of symptoms, presents with elevated acute phase reactants, did have a history of a compression fracture and type 2 diabetes. So would you start prednisone 30 daily with a taper, 20 milligrams daily with a taper, 15 milligrams daily with a taper, or would you add methotrexate with either 20 or 15 milligrams of prednisone, or would you add an IL-6 inhibitor such as tocilizumab or Actemra, or sarilumab? So this is interesting too. More people are, considering tocilizumab. I think there is a wrong answer on this slide, and I would say the wrong answer would have been starting 30 milligrams of daily prednisone. I think the other approaches are reasonable, but I agree I would not use methotrexate up front. So our general principles, we know we want to taper steroids, we want to avoid their side effects, we want to pay attention to relapses, but not necessarily overreact to that. We want to use the lowest dose that adequately controls the symptoms and recognize that flares are often easily treatable. That's going to be the challenge of knowing who to use a biologic in this disorder. And there have been other things used as adjunctive therapy. Again, this is in the syllabus. There are 3 RCTs with methotrexate, which suggested minimal benefit at best, but at longer-term follow-up, that was not sustained. There really was not clear evidence about methotrexate benefit, but I've used it in some people, wondering if they're really seronegative RA, actually. There's a very well-done trial by Carlos Salvarani of infliximab that showed no benefit whatsoever. And then some people have used leflunomide. Most of us don't favor using nonsteroidal anti-inflammatory drugs, but they can help in some patients, not surprisingly. But there have been 3 RCTs with IL-6 inhibitors recently that I'll mention, and I'm running a little long, but I'll mention them relatively briefly. All published, actually one was not published yet, the third study in the last year. And actually, while these slides were being shipped over here for the talk, the FDA approved sarilumab for refractory polymyalgia rheumatica. So that's going to be an interesting landscape and how this will insinuate itself into practice. This was the first study. This was, I think, an Italian study. It looked at a European study. It looked at new onset PMR. So these are patients that aren't necessarily refractory. I think it was about 30-something patients. It wasn't a large trial. And patients received tocilizumab or placebo in addition to a very rapid corticosteroid taper. So they were tapered off steroids by 11 weeks, and the primary outcome was at 16 weeks. Arguably way too early to be looking at your outcome measure in this disease, but they were able to show that a much higher proportion of patients treated with tocilizumab were in remission at 12 weeks and 16 weeks. And they didn't continue the tocilizumab out to 24 weeks, but the patients remained in remission at 24 weeks, a higher percentage of them. And not surprisingly, these patients also had less corticosteroid use and less relapses almost by definition. This is a different population and a different study published in JAMA last year from the French group. This was a study of patients, I think it was about 100 patients with refractory PMR. So most of these patients had disease for about a year. So these were the patients we encounter in practice where we wonder about things like tocilizumab or other strategies. And they had a complicated composite primary efficacy outcome, which was measured at 6 months, at 26 weeks. And it was this activity score for polymyalgia rheumatica, which incorporates the CRP. Obviously, that biases it a little bit in favor of a drug that suppresses CRP. But even without that, the results held up. But you did not have to taper off steroids by 6 months. You could be on 5 milligrams or less of prednisone and still be considered a success. And you had to have lowered your prednisone requirement by more than 10 milligrams from your baseline. So you could come into this study, which is unusual, needing, let's say, 16 milligrams daily of prednisone a year into your disease, and taper it to 6 milligrams daily, and that would be a success if you had low disease activity. But you could see, and I haven't figured out my pointer, that you were more likely to achieve that outcome if you were on active drug. But look at the prednisone dose. The dose difference was trivial. So it was maybe 6 milligrams a day at 6 months in the placebo group and 3 milligrams a month in the active treatment group. So it's a proof of concept. And this I'll try to talk about quickly. This is the SAFFOR trial. This is not yet published. It was presented at the ACR. This was an interesting design. It looked at refractory disease. You had to have flared while still on more than 7.5 milligrams of prednisone in the prior few months. And then you were randomized to either get sarilumab every other week and a very rapid prednisone taper over 14 weeks, or placebo and a kind of conventional 52-week steroid taper. And it was a composite endpoint, but basically you needed to it was actually a sustained remission. You had to have had no disease activity by week 12, when you were down to maybe 1 or 2 milligrams of prednisone at that point, and sustain that for the duration of the study up to week 52, and adhere to your prednisone taper as protocol defined, and have a normal CRP. And the bottom line is it was a very positive trial. So it doesn't look impressive. So it was about 30% of patients on active therapy achieved that rigorous endpoint, whereas only 13% of patients on placebo did. But if you looked at sustained remission or absence of a disease flare, it's more than half of patients on sarilumab with a simple 14-week steroid taper. And that probably means something, and could mean something clinically important in practice. Also, not surprisingly, there was less steroid use if you were randomized to sarilumab. We're not going to talk about PROs, but quality of life outcome measures favored sarilumab. So this, to me, was a meaningful outcome of the trial, because we have a really hard time capturing why are patients on 3 milligrams of prednisone maybe not doing well, or 6 milligrams of prednisone. They're not getting osteoporotic fractures. Maybe they have some skin fragility that isn't captured by other outcome measures. So the improvements in the quality of life measures, I think, was pretty important. So in terms of my approach, I usually treat with methylprednisolone just because there are some patients that are refractory or respond better to methylprednisolone than prednisone. I often will give them a divided dosage, even though the guidelines don't necessarily endorse that, with it front-loaded in the morning, but that helps with the morning stiffness often. I target a rapid taper. I'd like to see if these patients can get off steroids within 16 weeks. Remember, almost 20% of patients in some of those trials in the placebo group got off steroids within about 4 months. So I'd want to be part of that 20% if I had the ability to be that, recognizing I can always raise it. And I think about glucocorticoid sparing therapy if it's refractory, or if there's glucocorticoid intolerance. And the drugs I look at are methotrexate. I don't use leflunomide or hydroxychloroquine frequently, but IL-6 inhibitors may be something that we'll look at more, limited by access issues, but that might change. And of course, vigilance regarding steroid side effects. Okay, well, thank you very much. These are my colleagues at our center. And thank you, Jack, for having me.
Thank you, Rob. That was great.